Okay, everyone, let's go ahead and get started. Good afternoon, and thank you for joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I am a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We're excited to bring you this educational activity and introduce our speakers. Today's topic is hereditary tyrosinemia type 1, nutrition management, and more. Please note this program is being recorded. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the chat pane or the Q&A at any time during the program. Questions relating to product will not be addressed during this webinar. Feel free to contact your VitaFlow representative for product information following the program. I have the pleasure of introducing one of our two speakers today. Taylor Meller is a metabolic dietitian at the Children's Hospital of Philadelphia, also known as CHOP. She earned a Master of Science in Nutrition and Dietetics from Framingham State University in Framingham, Massachusetts in 2019. In Boston, Taylor started her career working as an outpatient pediatric dietitian at a Brigham and Women's Community Health Center and as a nutritionist for their WIC program. She has been in her current role at CHOP for a year and a half, but has been passionate about working with inborn errors of metabolism since starting her journey to become a registered dietitian. At this time, I would like to introduce you to my colleague here at VitaFlow, Elise Pelletier, who will introduce our second presenter.
Thank you, Michelle. Hello, everyone. My name is Elise Pelletier. I am the Territory Manager at VitaFlow Canada, and I have the privilege today of introducing you to one of the guest speakers, Marie-Hélène Bourdage. Marie-Hélène has been working as a dietitian at the Centre Hospitalier Universitaire Laval of Quebec in Canada for 25 years now, 22 of which were in metabolic diseases. She follows more than 150 pediatric and adult metabolic patients, including 31 patients with tyrosinemia. Marie-Hélène manages a Facebook page dedicated to the French-speaking community who have or care for someone with a metabolic disease such as PKU or tyrosinemia. Her great expertise in the field of inherited metabolic diseases makes her a recognized speaker at the provincial, national, and international level. Now, I would like to hand it over to today's presenters. Thank you.
Thank you, Elise and Michelle. Thank you very much for inviting me to present on that particular topic which it's a lot of patients of mine, so the tyrosinemia type 1. So I will begin by talking about the newborn screening. In our province, we've been screening for tyrosinemia since 1970. I want to show you the incidence of global worldwide incidence. We think that we saw in the literature that the incidence worldwide is about 1 per 100,000, 200 to 1 220,000 live births. In our province, we've been screening for tyrosinemia, PKU, and hypothyroidism since 1970, and some diseases have been added since then. We know that the testing for succinyl is the succinyl acetone level in blood because the tyrosinemia plasma level are not reliable measure. We could have many false positive. Measurement of tyrosine in blood spots was to be routinely performed by tandem mass spectrometry. However, tyrosine is neither a sensitive nor not a specific marker for tyrosinemia type 1. Most commonly, elevated tyrosine level are due to transition benign hypertyrosinemia in newborn. Elevated tyrosine with or without elevated methionine could also be seen in premature babies, sick babies on total parenteral nutrition, mitochondrial depletion syndromes, or other metabolic or non-metabolic liver diseases, including tyrosinemia type 2 or 3. Furthermore, many infants with a tyrosinemia type 1 do not have elevated blood disease level at least than 48 hours of life, the time at which blood is typically collected for newborn screening. In our province, we've been collecting the blood spot between 24 and 36 hours after birth. Next slide, please. So what we see, the incidence in Pennsylvania versus in Quebec province. In Pennsylvania, over the last 3 years, the average is 0.78 per 100 births. In New Jersey, it's 1 per 500,000. So about 1 case in every 5 years. In our province, it's rise up to 1 to almost more than 20,000 live births. But we have a particular area in our province that we call Saguenay-Lac-Saint-Jean. It's in the northeast of Quebec, that we found 1 case per less than 2,000 live births. In that particular area, they have a founder effect. We found 5% of carrier in those places, Saguenay-Lac-Saint-Jean. So you can see in the map that we put on the slide, the incidence worldwide depend on the country, and you can see the light blue for the French Canadian, that is the largest population of tyrosinemia. Next slide, please. So in our clinic, I will be speaking in Quebec City because in our province, we have 5 metabolic clinics. There's one in Quebec City at Schul Hospital. There's one at Sherbrooke. And in Montreal, we found 3 clinics, 2 pediatrics, one at Children's Hospital that is related to McGill University. We have St. Justin Hospital, and we have the CHUM that we see, they have an adult clinic there. So speaking for my clinic in Quebec City, we have actually 2 geneticists who do metabolic. We have more than that, but some of them don't do metabolic. So 2 geneticists who do metabolic. We have 1 pediatrician who is seeing confirmed diagnosis for tyrosinemia, PKU, and MCAD. So he's following them until 18 years old, and then the geneticist will take those patients. We actually have 1.5 dietitian full-time equivalent. The 0.5 was added in March 2019, which was such a relief for me at this time because the clinic was really too big just for me, as we're following pediatric and adults. So we had many pregnancy, took a lot of time. So my colleague Patrick Godet is really a good colleague and very helpful. We now have 3 nurses working with us and 5 genetic counselors. In our clinic, genetic counselors don't do metabolic, but we have to work together sometime in prenatal when they find perhaps mom having a tyrosinemia baby during the pregnancy and they want to have information. It happens that I met families before delivery so they can make their mind about the situation. So in my clinic in Quebec City, we have 31 patients with tyrosinemia, but in our province, actually following at Chicoutimi, in the north of Quebec, in the area that the founder effect is very high, they have a tyrosinemia clinic. They don't follow other metabolic patients, but they have many tyrosinemia. So there's a clinic in Chicoutimi, one in Saint Justin, and one in Quebec City. My colleagues in Children's Hospital in Montreal also follow, I think, 3 patients. Next slide, please.
I think this is where I take over. So I also wanted to say thank you briefly to Michelle and Lily Savetta for bringing me on to invite me to do this talk as well. Our clinic has a fairly large amount of tyrosinemia patients as well for the US, certainly not as much as Canada or Quebec, but we do have quite a few. So our metabolic clinic, just to kind of go over this briefly, is we actually have 8 genetic and metabolism doctors here. They split, the 8 actually are mostly just in metabolism, but they also work with genetic disorders that we do not see. There's 4 dietitians, 2 are more on a part-time, and then 2 of us are full-time. We have 2 CRNPs, so certified nurse practitioners, and a PAC, a physician assistant, that assists, our doctors and us as well. And we have 2 nurses dedicated to metabolism and 3 genetic counselors. So fairly large clinic. We have a total of 38 patients with hereditary tyrosinemia type 1. And this is data that is gathered over the last 5 years. And I looked, and we, for the most part, follow actively most of those patients. And then very actively, probably close to like 16 that we see on a very regular basis. All right. And then just to circle back to the pathophysiology of hereditary tyrosinemia type 1, in 1977, the defective enzyme was identified as, and I apologize if I butcher this, fumarate acetoacetate hydrolase, so FAH, I will call it from here on out. That is identified as the defective enzyme in this tyrosine pathway. So as you'll see with this pathway on the right-hand side, the tyrosine catabolic pathway, or pathway that it's going through to turn into different products for the body. We start at phenylalanine, phenylalanine to tyrosine. So many of you might be familiar with this enzyme, the PAH enzyme, that could be defective or is defective in PKU disorders. So we start there, phenylalanine to tyrosine, and then tyrosine has this downstream to fumarate acetoacetate. And that is where the enzyme, the FAH enzyme, is blocking it from further being transformed into fumarate and acetoacetate. From there, fumarate acetoacetate is converted to succinyl acetoacetate, which is where it has to shunt off since it can no longer convert to fumarate and acetoacetate. And from there, it turns into succinyl acetone, which is what we're measuring with blood spot levels, with blood tests and also with urine. So those 2, the fumarate acetate, so toxic compounds in untreated HT1 is the fumarate acetoacetate and the succinyl acetone. Those are the 2 compounds that are toxic to cells and to the body. If you look just below, the tyrosine turns into 4-OH phenylpyruvate. You'll see that the NTBC, that we'll get into a little bit later, the medication used with tyrosinemia type 1, is where it blocks that downstream effect. So there is a backflow back into tyrosine because it's a reversible step. So in the toxic compound, if treated with NTBC, is tyrosine. So that's the general pathophysiology of HT1. And then to talk about what actually occurs when fumarate acetoacetate and succinyl acetone are accumulate in the body is, so those 2 in particular that I said are toxic to cells, specifically hepatic, so liver cells, and renal. So you'll see with untreated HT1 hepatic disease, and there's a wide range of what you see in terms of how it affects the liver based on the severity, but you'll see hepatic cancers as well. An early sign with or without hepatic dysfunction is coagulopathy. And then it will also cause renal disease. So you'll see the Fanconi syndrome type tubular disorder, which is really, read what, it's almost like it's purging many different things from the renal instead of reabsorbing. So you'll lose many, let's see. It's a disorder of kidney tubule function that results in excess amounts of glucose, bicarbonate, phosphates, uric acid, potassium, and certain amino acid being excreted in the urine. So that can occur. And then the porphyric type crisis is also on account of really if I go back here, so succinylacetone is toxic to renal system, can cause the porphyric crisis, but they really blame this levulinic acid for the porphyric crises. And it directly inhibits the pathway for heme synthesis at the porphobilinogen synthase activity step. So the porphyrins will cause the neurological crisis. And the neurological crisis is an abrupt episode of peripheral neuropathy. So it can cause severe pain, extensor hypertonia, vomiting, paralytic ileus, muscle weakness, and even self-mutilation was in the literature. So that, and then obviously on account of all these things, hepatic disease, renal disease, the porphyric crises, failure to thrive is seen in the first days, weeks, or months of life, depending on the severity. And then, so juxtapose being treated with NTBC, the tyrosine clinical symptoms of an elevated plasma tyrosine levels really are the corneal disease. So the second bullet point, corneal disease due to tyrosine crystals in the eyes. And we'll talk more about this, but not all patients with elevated tyrosine levels that we've seen develop the corneal crystals, but with high, very elevated levels, you can see them. And then there's also described in the literature a possible relation to NTBC treatment of neuropsychological and neurobehavioral issues. So they've seen, low IQ, behavioral issues, cognitive decline, attention deficits. So these are some things that they've seen with the NTBC treatment. And you can read more about that in some of the references that we've put here on the slides. Okay, and then I'll go over NTBC as well. The nitisinone is the generic name for the NTBC. NTBC is just another shorthand name for it. And the long name for it is hydroxyphenylpyruvate dioxygenase, HPD inhibitor. So it's over here on the upper right-hand side. You'll see that the nitisinone comes in at this step between hydroxyphenylpyruvate and the homogenistic acid. So it actually blocks that step, and that reversible step back to tyrosine is what causes the accumulation of tyrosine in the plasma. So nitisinone, NTBC, was originally discovered or created as an herbicide called triketone. In vivo, it was found to cause reversible corneal lesions. It became available worldwide and was authorized by the United States Food and Drug Administration in 2002 and a European Medicines Agency in 2005. I'm not sure if Marie-Hélène has any.
Yeah, I have the same story about the herbicide. They find the corneal lesion in animals. That's how they find it at first. So I found it so wow that science can find that kind of thing. We began to use it before that by authorized special access. Some of our patients, I think the first time we used it in the province was in 1992 on patient who had big neurologic crisis and by special access. And I think it was on the research protocol at that time that Dr. Grant Mitchell in Montreal had it.
Yeah, it's got a very interesting history, and good thing that it was found, because what it does is it blocks the HPD enzyme from catabolizing tyrosine to the more toxic fumarate acetoacetate and succinyl acetone. So it'll block a much more dangerous metabolite and accumulate the tyrosine instead. Dosing works, they come in terms of, how it's dosed, a capsule, oral suspension, or tablet. And the maximum dose is 2 milligram per kilogram of body weight. And I spoke with, some of the physician assistant and the physician, one of our physicians about this, and they tend to go for the maximum dose and then start to pull back from there because of what it does. We want to make sure that we're really pulling away from that succinyl acetone and the other fumarate acetoacetate. And it's important, like I said, without NTBC, HT1 was very likely fatal before treatment with NTBC. So early treatment is essential. And I will hand it back over to Marie-Hélène.
I wanted to talk to you about the research protocol and NTBC in the Quebec province. We wrote city, but it's in the province. It's been leading by Dr. Grant Mitchell in St. Justine Hospital. Data have been collected since 1984. That's information that I took from a presentation from Dr. Mitchell. From 1984 to 1994, he collected data by a group of patients on nutritional therapy only without NTBC. Then the NTBC came up, I think it's in 1992. We see 1994 on that slide, but I think it's 1992. After a positive newborn screening for HT1, children in our province are actually hospitalized for 4 days to start the NTBC protocol. That's a protocol that Dr. Mitchell pulled up. It's kind of being reviewed at this time after the pandemic situation that changed the way that we could travel in our province, and hospitalize the patient was not easy. Many of our geneticists in the province asked Dr. Mitchell to review that protocol, and it has to go through ethic committee to be still legal at this time. So we still follow that kind of protocol and collecting data because we have such many patients. So collecting data for the future. As the NTBC is such a young drug, 30, 40 years, it's still young for a drug. So we don't know what will be the consequence or not in our patient in 20 years, for example. So actually what we still do is hospitalize the patient for 4 days to start the NTBC protocol, to collect urine and blood draws, and there's a protocol for 4 days. And then we have a clinical follow-up every 3 months. But when they're younger, so when the baby has been diagnosed, we're seeing at week 1, then week 2, then at 1 month, and then every 3 months. So that's how we do. But as we have in our hospital, not only in the province, in my hospital, when we have a newborn with HT1 referred to our center, we have a very large territory. So it's not always easy for the family to come over Quebec City. Sometimes they come from 12-hour driving. They don't have family support around them to help. So it's not always easy. And actually, the protocol asks for our family to go at St. Justine Hospital, meet Dr. Grant Mitchell once a year. But there's something that we think could change in the future since the pandemic situation happened, and many of our families don't want to travel anymore to Montreal because before Dr. Michelle said you have to come once a year. You have signed the protocol, so the family was very happy to go and to maintain that protocol. But with the pandemic, they could do the tests in their city, so in their hospital. So they are now contesting about missing school, missing work to go in Montreal, as they did during the pandemic. They did it at home. So we'll see how the research protocol we're going further. But for now, Dr. Mitchell is still collecting data for all of our patients in the province. And I know he does many presentations around the world about it. So it's really interesting. Next slide, please.
Now I will go over the dietary interventions for HT1. So kind of how we, since using the NTBUC treatment, we have the buildup of the tyrosine. So now we need to, give dietary interventions to limit the tyrosine in plasma to prevent those corneal lesions and anything else that have, consequences of an elevated tyrosine level. So one very important thing is teaching patients and families to read food labels and actually count protein. Maria Lynn and I, have talked a lot about the fact that many of our patients have difficulties with counting or maybe reading food labels. So we tend to use a simplified diet for some of our families or patients where counting is a challenge. So like I said, cultural, language, educational barriers can prevent, someone from being able to effectively read food labels or count protein. So what we do in a simplified situation is teach which foods are lower in protein, so which foods they should be focusing more on, and which foods to either limit, or the foods that we should always avoid to limit high protein loads. And then an essential component to our diet therapy or diet intervention is a metabolic formula. And it's common to use a variety of formulas to achieve, the protein equivalents that lack the phenylalanine and the tyrosine to meet, individualized diet plans. So depending how their lives are, busy lives, how old they are, there are many components that go into our decisions of what formulas would be best for a patient, and working with them on that is essential. And then to go over what the actual goals are. So that was, how we approach the dietary intervention, but we have specific goals in mind to that we don't want to achieve with those dietary interventions. So first off is the tyrosine plasma levels. So this is one of our key targets, is trying to get the plasma levels within treatment range. So for our clinic, we tend to focus on, or we do focus on less than 600 micromoles per liter. And I was discussing with Maria Lynn that they will also use 200 to 400 for young children in Quebec. And let me know, Maria Lynn, if you.
Yes, we have some old geneticists that still aim for that target. There's no scientific references for that, but before the guidelines came up in 2017, that was the target that Dr. Grant Mitchell had in his protocol. He is a co-author of those guidelines. So we aim also for less than 600, but some of our geneticists still want us to try to go more than around 400 and less for young children. But we agree as dietitian as to less than 600. So we just work with our physician and our family. We explain that also to our family, so they don't panic if they have a tyrosine level for the kids that is around 500 or 600, then they do not panic about it. We will explain
Perfect. And then when I spoke briefly, before about that tyrosine pathway, how we start with phenylalanine. Phenylalanine is another amino acid that we are targeting as a limit in the diet because taking in phenylalanine will convert to tyrosine. So we do find that when we use the metabolic formulas that lack the tyrosine and the phenylalanine, and we're limiting protein in the diet, that phenylalanine levels, plasma levels, will also decrease. So we find that we're trying to keep them within the normal range. So this reference is between 20 and 80. Our clinic will use the reference range that we have for our lab, but in general, the guidelines dictate do not go below 20 micromole per liter to keep phenylalanine levels within a normal range. And in order to achieve the two goals of phenylalanine and tyrosine, we really need to work with our patients to determine their individual, complete protein tolerance to be able to provide enough tyrosine and enough phenylalanine to keep their levels within these goal ranges. So some of our patients, we ask them to keep a food log so we know how much protein they're taking in. And usually we see that the complete protein tolerance is higher with tyrosinemia type 1 patients than it is for moderate to severe forms of PKU if you are familiar with that disorder. And then other goals of the dietary intervention really are more of a general general dietitian goals, which would be meeting total protein for growth and development, calories as well, growth and development, and then those vitamins and minerals needed for many different functions in the body. So we're keeping in mind, our general goals for nutrition, but specifically with tyrosinemia type 1, we want those tyrosine and phenylalanine levels to be in our goal ranges. And then to comment on the complete protein tolerance, we find that tolerance is completely variable. It's very hard to predict how much protein our patients are going to be able to tolerate, and it's very, very person to person. So that's why we need those plasma levels of the phenylalanine and tyrosine to dictate how we change things. And Maria-Lynn, wrote here that the Quebec clinic reports adults who can tolerate up to 30 grams of complete protein, and I've also seen pretty high, similar, but it is completely individual. And because the protein, it seems like a very, quote unquote high, large amount of protein that they can tolerate, but, we still recommend that meat, eggs, dairy are avoided completely, because if you are meeting half of your complete protein allowance with one meal or even a couple of foods, you will most likely consume inadequate calories. And then the other flip side of introducing foods that are too high in protein, if you introduce them when the child is, an infant, or you're introducing solids, or a toddler, when they're only eating small amounts, and it might not result in a high tyrosine level. As that child gets older and they're eating larger quantities of food, those portions get bigger and bigger, and then all of a sudden they're consuming much more protein in one sitting, and that will result in elevated tyrosine levels. And then having to take away a food that a child has gotten used to eating is much more difficult and becomes much more of a challenge later in life. And then, like I said earlier, we rely on plasma amino acid levels to really adjust the nutrition therapy. So in order to determine complete protein tolerance, we use those plasma amino acid results. And we also, base it on, their diet record, how much protein they're taking. We use the plasma amino acid levels to then titrate different, either the phenylalanine or tyrosine based on the protein they're taking in. And then the difficult part with some of those patients I described on a simplified diet is that having those plasma amino acid levels are a great thing, but if we don't know how much protein they're taking, it's very difficult to tell them how much to decrease. So when I have patients who we're just avoiding, meats, dairy, eggs, and those very high protein foods, and they consume, moderate protein, maybe beans, tofu, and they also consume the low protein foods, grains, fruits, and vegetables, but they have an inability to give me an analysis that I can make of how much protein they're taking. I am very limited in what recommendations I can make, but we work very closely with our families to try and do the best we can with maybe limiting those moderate protein foods or working with them on the types of foods they're eating. So there are things that you can do to help bring their levels down, but it just becomes more of a challenge, which was the point of that. And then monitoring. So other than monitoring the tyrosine in plasma and phenylalanine levels, which are actually encompassed in that plasma amino acid profile, we have other monitoring that we're doing to make sure that the diet is adequate, medication management is appropriate, it's, the actual treatment is working. These monitoring are, from dietary adequacy and compliance, dietitians are going over the diet, food frequency, we're looking at growth patterns, we're making sure that they're getting enough protein and enough calories. So this Marie-Hélène can also chime in on for the dried blood spots for young children. So just for our clinic, I discussed with my colleagues that the dried blood spots that we use for our PKU management, they report out a phenylalanine level and a tyrosine level when families do these filter papers at home. But the labs that we use New Jersey and Pennsylvania labs to do these blood spot analyses, and they reported that the validity of their tyrosine levels has not been established. So they don't recommend that we in particular use tyrosine levels on their blood spot filter papers. But I'll let Marie-Hélène talk about that as well if she wants to comment.
Yes, we use dry blood spot for our young tyrosinemia patient as a marker to adjust the diet. And because we have so many patients coming from very far from our hospital, it's really hard to have the plasma amino acid profile to be done. And we use the health system to send the blood spot more rapidly to the lab in Quebec, so we can have the result many days before we could have the plasma amino acid result. Our plasma amino acid have been analyzed in Sherbrooke, so for us it's more useful to have dry blood spot to adjust the diet with the young infant and toddlers. I said that we stop using them from 4 or 5 years old, depend on their stability of the tyrosine, but it's really useful for us. So that's why we're still using it.
And then also the other monitoring we do is the NTBC plasma levels. And Marie-Hélène said in Quebec, they do them for all their patients. They take these NTBC plasma levels at clinic visits. And I spoke with my colleague, and actually we recently also started doing that as well. So every clinic visit, we will measure the NTBC plasma levels to make sure that we are staying in a treatment range for NTBC. And we'll talk more about that in later slides. Other things we check is the urine organic acid. So getting that succinylacetone level to make sure that it is low or not there, to make sure that the treatment for NTBC is actually working. We measure the alpha-1 fetoprotein levels, which is a marker for liver cancer. And you will see once an infant or child starts the treatment, you'll see that level alpha-1 fetoprotein start to decline. We also do liver imaging yearly And then we also will check periodically, check micronutrients such as vitamin D, iron, selenium, and then dietary monitoring of calcium and provide supplementation as needed. And then I will hand it over to Maria-Len, and if you had any comments about monitoring.
When we added the guidelines in 2017, they said to supplement in phenylalanine if blood level was below 2 micromoles per liter. They said additional protein should be added to the diet from milk or food. And that's funny because, can you go to the next slide, please, Taylor? Maybe 10 or 15 years ago, before we began the supplementation in phenylalanine, Manon Bouchard, my colleague in Saint Justine, tried to find food that had a bigger ratio of phenylalanine for tyrosine, higher than 2:1. So maybe we can try to increase those food in the meals during the day to increase the the phenylalanine and not to increase the tyrosine. So that's a part of the chart that she built up at that time, just to see that we tried that, to ask the patient to eat more of those foods to rise the Phe level, but it just didn't work. So that's where we started to supplement. I think it was 10 or 15 years ago. So you can come back to the preceding slide, please. So in our clinic, it's really physician dependent how supplement will be given. Some of our patients will take 45 milligram up to 100 milligram 3 times daily. It represents between 12 and 17 milligrams per kilograms per day. We have mostly pediatric patients that have supplement. I think we only have 1 or 2 adults on supplement, actually, on supplement. So you can go up to the next slides. So Taylor and I have been discussing about the availability of the formulas in our state and province. So all of the formulas available in the market, I think we have all access to. But for Pennsylvania, it's depend on insurance for being paid. But in our province, we are so lucky to have a provincial program that we have all the coverage is secure for all our patients, that pediatric or adults at any time. So we can use any of those formulas as we want to. And it's the same for the low pro food. We have a coverage, a large coverage in our province. We're so lucky for that because it's really, really helps for the compliance to the diet. And we can use more than one type of formula to get easier to fulfill the needs of our protein equivalent for our patients. So that's really nice. Next. So just for example, in our clinic, I gave 3 examples there. We have a 5-year-old who's taking AA formula for breakfast because he was on amino acid formula for a long time. And he likes it, so I didn't want to change all, but it was a big volume for him to take. So we started the gel at school for lunch. So it was easy for him to take. The mom is preparing it in a small cup in the morning. And at school, he's having different kind of Mio drops. So that's flavoring drops that he can add to his gel. So he's choosing the flavor each time that is having his gel at school. So he's having amino acid formula at home for breakfast and dinner, and tear gel for school. We have also adults that are using different type of GMP formulas during the day. They will have one ready to go to put in the cereal in the morning. We have an adult taking a vanilla GMP formula mixed in the coffee at the office. So she switches formulas during the day, but she knows that she have to to go to rise to 50 grams of protein equivalent during the day. So she split it with different things during the day, and that's really helpful because it is avoiding the taste fatigue for her. So that's what we like. Sometimes they ask, that is the patient who will ask us to have different type of formulas, but sometimes we will propose to them because they're struggling with just one type of formula. We had one kid is now 12 or 13 years old. I think this teenager, he wasn't able to take the formula for many years when he was young. And when the tablets came on, he tried to take the pills. So he started to take only the tablets, splitting in the day. And as he was growing up, it was too hard to take all those tablets. So he's now at 33 easy tablets. So that represents 30 grams of protein equivalent, and is having a 20 gram of protein equivalents by GMP formula. So since we finally find that with him, he accepted to take that. It was his choice. We now have a plasma amino acid profile that is completely normal and well-controlled tyrosine too, because when they are missing protein, total protein in their needs, we see the tyrosine go rise up because of the catabolism. So those are 3 examples that we have in our clinic. Next. So we have all of patients on NTBC in our province, as everywhere in the world now. The oldest one is, she's 49 years old. She's been following actually in our clinic for maybe 10 years. She was in Montreal before, but she refused to see a dietitian. She was refusing it in Montreal. She still refused in our clinic. So she only see the nurses and the geneticists. She's on a formula, and I know she's not having constant meat or cheese, but we don't know what she's having for diet, and we're not following her at all. So, but I know she's 49 years old on NTBC. I'm reporting, this is not a scientific data, but Manon Bouchard, my colleague in Montreal, did a survey in our province in 2018 to see how many of our patients was on a GMP-based formula. And we find out that almost half of our patients are taking a GMP-based formula in our province. I think everywhere that was a revolution to having those GMP formula for our metabolic patient, PKUs and tyrosinemia. At that time, 10 patients were doing a combination of a GMP-based formula with amino acid formula, like coolers or other regular formulas, because they still like their old formula that they've been using, but as they needed to take such a big volumes, they wanted to have mixed products. And we had at that time 47 patients who were strictly on GMP-based formula. So that I thought that it was an interesting data to share. Next. Issue with adherence to NTBC. We talked about it, Taylor and I, also because she had some patient that misses those, and we wanted to find out why our patient missed dose of NTBC, as that drug is saving their lives. We have a case in Montreal. It was a teenager. She was 17 at that time, and she decided she didn't have tyrosinemia anymore, so she completely stopped taking her NTBC without telling her parents, and she began to be really, really sick with muscle pain, and she was in neurological crisis. She needed to be hospitalized for many weeks because she had such a big neurological crisis that she lost the use of her leg for a while and need to go to rehab. So at 17, she went on Facebook and on other social media to tell other tyrosinemia patients, don't stop taking your NTBC. It saves our lives. Don't do what I did. But still, we have patients who are missing doses, like diabetes, who will stop taking insulin, or it's really hard with chronic management disease to be always compliant. We had a patient 3 times being hospitalized between the age of 10 and recently is now 21 because he had missing doses of NTBC. So the consequence also that we see with those missed doses is that the tyrosine will go down. So if you have patients with that that are not really compliant to their diet, and you have a tyrosine result that is low, maybe ask if they are always taking their NTBC, are they missing doses? Because if they're not taking the drug, the block is not there, so the tyrosine go down the pathway, and so that's why the tyrosine level will go down. So NTBC blood level are frequently measured based on age and our compliance. We're checking every 3 months when they come to clinic visit. Some of our older patients don't come to clinic, but they have to do blood draw every 3 months. So we get the result and we have a follow-up by phone at that time. But we check every 3 months, and the gold plasma level for our province, we aim to have the NTBC level higher than 50 micromole per liter. Next.
All right. And then in addition to challenges with taking the NTBC treatment, we also see challenges with dietary management. So first off, I think no surprise to anyone, the formulas, or metabolic formulas, or it might be a surprise, metabolic formulas do not taste or smell wonderful to most of us. And even those patients who have gotten used to taking it since they were infants, may not like it as much when they get older. So that can also occur. It's also for powder formulas, or there's daily preparation. So every morning you need to be organized enough to be able to pick a time to mix your formula, figure out how you're going to store it throughout the day. Some families or some patients will only like it cold, so they need to have a place to put it in work or school. Some patients have large volumes they need to consume to get enough of their protein equivalents. And we also recommend usually splitting formula up throughout the day. For us in our clinic, we recommend at least 2 to 3 doses throughout the day to kind of split that protein equivalent up. So not taking it all in one sitting. So it can be a lot throughout the day to organize that. Diet therapy itself. So the formulas are part of the diet therapy, but the low protein foods are an essential part of that. And in addition to foods that are naturally low in protein, fruits and vegetables, there are specialty low protein foods that are designed to be high calorie, low protein per serving. And they have a very different, taste, texture, appearance. You might be familiar with gluten-free products, just as a juxtaposition that they, have gluten-free pastas and gluten-free this, but the texture is going to be different than a normal pasta, and that's similar to low protein medical food. The texture is not going to be the same. So that might be, a challenge for some people who might have family members who eat the normal version of the usual version of what they're eating. There's also a limited variety of low protein foods, which is a challenge. Counting protein is time consuming. And, if you're like me and have a very busy day, writing down every time you eat something on the fly is very difficult. And our patients are no different. They also have busy lives. So counting protein can be a challenge, especially also with parents who have infants and toddlers who throw things on the ground or have dogs that eat the food that the child doesn't eat. There are many challenges to counting protein. And then to talk more about the actual foods of being different than the rest of family, many families have to make 2 meals. So one for their child that's affected with tyrosinemia type 1, and then for the rest of their family, if they have other unaffected children or other family members, they have to make a completely separate meal. Meats and or fish might be part of either family norms, tradition, or cultures. So, providing a meal that doesn't have that same component that other family members are eating is a challenge, to make that child feel, part of the family unit, feel normal. It's a challenge for the families and for the patient or child or adult. And Maria Lynn also touched on this coverage for medical foods and for formula. In Quebec, they have a fully covered formula, fully covered low protein medical foods. And, to the USA, we have this special challenge of having insurances dictate coverage. So we find that for formulas, they're most often, fully covered, or there's a very small copay, something like that. It is insurance dependent, and it can be more difficult for our adults. We find that adults on our, state-run programs or the Medicaid, those types of programs, they don't cover oral formulas. They will only cover it if it's through a feeding tube. So that's a specific challenge with the medical formulas. And then with the low protein medical foods, it's very variable whether they'll be covered. We have been getting more coverage for some of these low protein foods, but it's very insurance dependent. And there's a link down at the bottom that Maria Lynn had provided for their list of nutritional products that are covered by the Quebec Food Program, if you're interested in seeing what they have coverage for. And then I think I touched on some of this already, so I'll kind of briefly go over it. So some of the challenges with different age groups with parents is for infants and toddlers. So again, mixing those special formulas, the acceptance of the formula. So if you're trying to introduce something later in life versus as an infant, you might find that they will reject it entirely, or there might be this slow rejection of a formula and you have to troubleshoot later how to addend it or how to fix it and make sure that they are taking their formula. It's a challenge. Variable intake, so toddlers can have one really great day of eating and then one really very bad day of eating. So it's just it's a roller coaster with toddlers and those picky eating habits as well. So not only will they have days where they're not eating as well as others, they will also reject things that you've offered. So you might have a really great plan in place for how much protein they're going to take, and your plans are all for naught. And then the school age and adolescence have its own challenge.
Can I just interrupt because
please.
I'm just thinking that we have a recent baby. He's now 6 months old, and mom is a nurse, and she wanted to do the baby-led weaning with him. So we're doing it with him. So we propose low pro food, and how that's a challenge to this time not to have low tyrosinemia food, but higher tyrosinemia food, because it's hard to know what he's having. But we decide to go with her and try to go with the baby-led weaning. So that's a thing we've been asking for our patient too. So go with them.
Yeah, I think that's a great point, Maria. And I have a different disorder, but similar protein restriction, and they wanted to try baby-led weaning. And I think what I recommended was, because they are good with, weighing foods. This can be a challenge with patients who, they don't use a gram scale or they're not really measuring. But I said to weigh it before and after the child eats. So that way you can, by subtraction, figure out how many grams the child has actually eaten. But I think is a very popular thing that people are doing right now, or parents are trying. So definitely working with them to meet their own goals is very important. So that's a great point. And then, as I was saying, with the school age and adolescents, a very unique challenge is that they, want to be like their friends, and they don't want to do what their parents tell them or what their doctors tell them. And they tend to have a decrease in formula consumption. They're busy, they don't think about it. They have friends to hang out with. They might not bring it with them. So their formula consumption might go down. They might, because of those same reasons, eat more phenylalanine and tyrosine through their complete proteins. They might overeat complete protein. They might miss NTPC doses, as Breland was already talked about, trying to remember the doses, or they might be busy and leave too early in the morning, not take it, various reasons they're missing the dose, but others are because of this, regular meal times, so they might not be eating as regularly. I have teens that won't eat breakfast, won't eat lunch. They might eat when they get home at 2 or 3 p.m. So it's very irregular the way that they eat. And then beginning of alcohol consumption in adolescents can, be a challenge, because inhibition is decreased with alcohol consumption. So they might be more likely to eat high protein foods or any other challenges that comes with the disinhibition. And the way that alcohol affects the liver, there are many things that the alcohol can do. I won't get into, but other is parental attitude, direct effect on the child's acceptance of nutritional therapy. So if a parent is either there's, wide spectrum of how a parent comes about, or handles these dietary restrictions. And, from one end, you can have a parent who is very on top of it, kind of taking control of everything. And then another type of parent could be very laissez-faire and, lets the child figure it out. And so there's a wide range of the types of attitudes that parents can have surrounding nutritional therapy. And it's we are tasked with trying to figure out how to work with different parental attitudes and to make it work for the child and work for the parent. But it can have a direct effect then on how the child accepts the nutritional therapy. So they can be more likely to easily reject it if they're in charge of it, is what I've seen from an early age. And then overcoming some of these challenges. So definitely a positive parental attitude. So there are different ways that parents can handle it, but regardless of how they handle it, the attitude can make all the difference. So they're trying to encourage their child, or can make a huge difference for success. Positive couple dynamics and a positive family relationship. So the way the family dynamic can also affect the compliance for dietary therapy. Parents meetings, so there are support groups, there's lots of different resources out there so I know a lot of our families will have parents with children with similar disorders that they can talk to for support and for ideas. I think one of the big things is families sharing recipes for low protein foods or products, or things that support their child and make them have a more varied diet or a more exciting diet. And then again, social networks like Facebook, so parents can find ideas, recipes, support, anything on the social media platforms. Relationships with the medical team. So when we have a close relationship with our patients and our families, we find that we're able to work better with them. We're able to help them through challenges, and they can rely on us, and we can really, help them. So it's really important to have a good relationship with your patients, with your families, and they in turn will have a better relationship with you. Involving a social work within the metabolism team. So we have a social worker that if we find that families are struggling with, within the family, within their school system, if they're not really providing the support that the family needs, or the work is not providing the support, we're able to involve, a third part, our social worker as the liaison between these institutions to be able to help support these families and these patients. Do you have a social worker in your clinic as well?
We don't have directly a social worker, but we can refer to one. But sometimes it's really hard to have the services really quickly. Sometimes we need to wait, which we have.
Perfect. All right, so that is kind of, I'm going to lead into my case study now. And I aptly named this case study Road Bumps because there are many different challenges that we encountered. So AR is our 9-month-old tyrosinemia type 1 patient. Mom and dad are from Pakistan. Family history is significant for multiple family members diagnosed with tyrosinemia. He was transferred to our care at 4 months of age. Initially came on 4 fluid ounces twice daily of a tyrosine and phenylalanine-free infant formula. So he already came in on a specific regimen, which was its own challenge because we didn't get to really start him off and follow him. All other feeds came from a hypoallergenic infant formula due to a past medical history of bloody stools with human milk. He was presumed to have a cow milk protein allergy, and that was mostly resolved after the switch to the hypoallergenic infant formula. So on his first appointment labs, we noticed that his tyrosine plasma level was 591, phenylalanine about 50. So phenylalanine was in a good range for us. So was tyrosine, but it was in the upper end of our goal treatment range. So after this visit, we recommended increasing the tyrosine and phenylalanine-free formula to 4 bottles of 4 fluid ounces, spread throughout the day, all other feeds coming from the hypoallergenic infant formula. And the rationale for this was that the family had just started providing solids, so he'd be getting more protein, so that tyrosine might increase a little bit more. And also the NTBC treatment was increased from 0.75 milliliters twice daily to 0.8. It wasn't a huge increase, but it could affect the tyrosine levels. So that was the initial recommendation upon seeing him. He repeated labs about a month later, and the plasma tyrosine level had gone down with the increase in the formula. The phenylalanine and tyrosine-free formula, but the phenylalanine plasma levels had dipped below our reference range for normal phenylalanine levels. Because of this, we recommended, and we knew that he was still ramping up his solid food intake. We said no changes because the tyrosine was in range, and we thought that the increase in some solid foods would increase the tyrosine a little bit and also bring up the phenylalanine. And then an important thing to note that the infant was originally when he came to us on the hypoallergenic infant formula. Mom had always intended to try human milk again because she really wanted to provide that. So between the first visit and the repeat lab, she had actually trialed and did well. He did well and switched back to human milk. And so what I didn't realize at the time, and that I wanted to share with you all, is that human milk has 28 milligrams of phenylalanine per 60 milliliters. And the hypoallergenic infant formula we were using, the EleCare, has 87 milligrams of feed phenylalanine per 60 milliliters. So it is a very significant difference between the two formulas. And you'll see that when we repeated again 1 month later, the tyrosine was again, in a good range for us in terms of the treatment range, 385, but now the phenylalanine level was 11. So it had dipped pretty significantly. Our recommendation at this point was to decrease the tyrosine and phenylalanine-free formula by 15%. So now would be taking 14 fluid ounces. Prior had been taking 16. All other feeds would come from the human milk now instead of the hypoallergenic formula. And the next appointment was about 1 month later. And at this point, since we had made those changes, the tyrosine level was now 462, still within a good range, and phenylalanine dropped to 4.9. So it had dropped very significantly at this point. And mom reports that he was, taking the 14 fluid ounces of the special formula as prescribed. He was PO ad lib, drinking the pumped breast, human milk. And then mom reported that he, with that PO ad lib, he was taking an additional 17 fluid ounces of the human milk, which is about 29 milligram per kilo of phenylalanine, 238 milligrams, which is a good amount in terms of like the PKU recommended amounts for keeping in range. But at this point, he was taking small bites of fruits, vegetables, and rice 2 to 3 times daily, but mom was not counting protein at this point. We had to rethink our approach at this point because the phenylalanine was so low. So we recommended to change, to focus more on titrating the human milk versus titrating the special phenylalanine tyrosine-free formula, because that didn't seem to help us with figuring out how much complete protein he was taking. We really needed to know how much complete protein, and rather than try and, bring up and down the special formula. Usually we will choose the titration or bringing up and down the phenylalanine and tyrosine-free formula if mom wanted to feed right at the chest, but if she didn't, because in that way we can figure out, the baby will make up the complete protein if we pull away some of the special formula, or vice versa. If we bring up the special formula, the baby will take more complete protein from the human milk. But in this case, since she was pumping, we turned our focus to the complete protein from the human milk. And at this point, it's important to note that the tyrosine was too close to 600 to increase the human milk further, but the phenylalanine was so low that we had to start a phenylalanine supplement, and we dosed it at 50 milligram per kilo per day. And at this point, a very important note is that the NTBC treatment was increased to 2 milliliters twice daily from the previous 0.8. So it was a very big jump in the dosing. So you'll see on the second appointment, repeat labs, the tyrosine level is now above our treatment range, so 748. But phenylalanine was on the low end of the reference range of normal. So at this point, we decreased the human milk, since that was our new focus, to 18 fluid ounces from the previous 20, about a 10% decrease. And we're still working with mom to try and get her to, count the protein. We requested a formal diet record to analyze, so that we can then, work with mom more on how much protein he's taking and how she can count it. Another important point is that he started having itching at his eyes, and that we are still unsure because he hasn't seen ophthalmology, but we thought that it could be corneal crystals from his high tyrosine level, as the repeat lab draw didn't happen until about 1 month following the appointment. So he could have been sitting higher for about a month. And then the repeat before the third appointment, tyrosine levels had climbed even further to 831, and phenylalanine was only 31, so just on the bottom end of the reference range. Again, we decreased the human milk to 14 fluid ounces, all other feeds, tyrosine, phenylalanine free formula. We have not received a formal diet record, and the third appointment was a little difficult to gather a prior diet history. Repeat labs after the third appointment, and filling out a diet record was what we had recommended at the end of the appointment. We still don't have those levels back yet, so we don't know how these recommendations have affected, but I am very sure that we will need more of a phenylalanine supplement because of how low that phenylalanine was with such a high tyrosine level. And this is just a graph I thought was really interesting, and my colleague recommended doing, because it really shows what happens with these major changes. So on the left, the tyrosine plasma level comes at the first appointment, it was a little bit elevated. We made changes. It started to come down. It was in a good range. And then around the second appointment, we had increased the NTBC. We had doubled it, more than doubled it. And so you can see that tyrosine level just start to skyrocket up. And then on the right-hand side, the phenylalanine plasma level between the first appointment and the repeat one, mom had switched to human milk. So you see that this downward trajectory of the phenylalanine level. We started the supplement at the second appointment when the Phe was at 4.9, and we see it climb back up. But as it's climbing up, so is that tyrosine plasma level. And then by the third, before the third appointment, we see it come back down. So there's going to be, significant things we need to do in order to manage those two levels. And it's a constant challenge that Maria-Ellen is very familiar with. And then, key takeaways from this is type of complete protein provided, formula versus the human milk versus foods vary in the phenylalanine and tyrosine content. Keep in mind the NTBC dosing changes because it really will affect your nutritional interventions. I already spoke about this, the formula versus human milk titration, and how to determine which one you want to start bringing up and down. Teaching the art of diet records early. So aim to start, when they really start taking a tablespoon or more per sitting. And the observable symptoms of a high plasma tyrosine level, there really aren't any. So some patients can have corneal crystals, but not always, even with prolonged exposure.
Okay, I'm taking this up with the pregnancy and human milk. As our patients are getting older with the NTBC's treatment, we now have pregnancy and tyrosinemia type 1. There are not many cases reported in the literature. The first one was reported in 2011. That's funny because I was at Metabolic University when the dietitian from Netherlands came up to me and said, my God, we have a pregnancy. It was in 2010. And she wanted, what are we doing? I told her, I don't know. I think you're the first one. So that was back then. Since then, Quebec province has now 6 pregnancies. 5 has been following at St. Justine Hospital, and we had 1 in Shoal in our hospital. Actually, Philadelphia do not have any pregnancy yet. What we did, what is really, really important to maintain during pregnancy and trying to do before pregnancy is to have a phenylalanine and tyrosine restricted diet with formula supplementation, to be strict and well controlled. That it's in an ideal world to have a planned pregnancy and to be prepared. High plasma level tyrosine during pregnancy can affect fetal development, intellectual and developmental delay, microcephaly, low birth weight. So that's why we need to have a good control during pregnancy. Close monitoring is necessary. Plasma amino acid profile, NTBC blood level, and regular labs for pregnancy to be following. There's something in the guidelines about it. Next, please. Most important, NTBC must not be stopped. Even though if we know that it crosses the placenta, that we found it in maternal milk, for the treatment, we need to maintain the NTBC. The guidelines of 2017 mentioned that breastfeeding is contraindicated for mothers on NTBC treatment as it cross that we found it in maternal milk. But I found one case report of breastfeeding with tyrosinemia in 2021, so pretty recently. It was, I think, 2 pregnancies have been, they allowed breastfeed for 2 weeks. So I think we will have in the future to think about what is the best for the babies is to having the all the goods that we found in human milk, beside the NTBC that cross the barrier and goes in the maternal milk, so that it makes a block for the baby that doesn't have the NTBC, that makes still the tyrosine rise up on the baby, even though it doesn't have the tyrosinemia. So we will have to think about it later on. Next. That's why I decided to present this case, the maternal case that I had. This young lady was born in 1993. She was a homozygous for French Canadian mutation. She was detected by newborn screening, and NTBC was started at the age of 2 after a neurological crisis. I found out all the old paper in her medical file for a special access to the NTBC. It took 2 weeks before they had the drug at that time. So that must have been so scary for the family because the baby, she was really sick at that time. She's a patient who lives in the north of the province, so very far from the hospital. She came from a very poor family. They don't have they have financial issue. She didn't have the capacity to have a high level of education. So she's having trouble by counting proteins and just do the dietary record for her is really, really hard. In her story, she had the bad luck of having a diagnosis of leukemia in 2019 with tyrosinemia. She had to come to be hospitalized at L'Enfant Jésus, that is another hospital in the Quebec City, for chemotherapy and all the treatment from May to December 2019. So I've been working with my colleague dietitian over there during therapies to try to make her eat, to have her formula so she can go through that journey. But that's not what I want to talk about today. I wanted to talk about her pregnancy. It was an unplanned pregnancy. She was 28 years old. She announced that news at our team in November 2021. Like I told you, she come from very far from Quebec City, so that was a challenge for the follow-up of that pregnancy. Next, please. It was so hard to estimate the needs. I don't know how you guys are doing with obesity, but this patient, I've been knowing her from since 22 years now, and she always been obese. Her mom is obese, so I put you a little of her weight up and down before the pregnancy and after. So the first weight that I have is when we heard about the pregnancy. That was the second one at 100 almost 34 kilograms. It was in September 2021. So during her pregnancy, we wanted for her not to gain weight, just to adapt her food to be more nutritional, and for her to having formula, which was really hard for her to fulfill her need. So we estimated her needs for pregnancy with adjusted weight that we did, but it's such difficult because the BMI was over 50, so it's hard to, even though we have way to estimate the needs, we needed to adjust with every labs that we add. So just to make sense, did she have enough calories, enough protein with the amino acid profile that we had? So we estimate that's a large estimation between 2,165 and 2,500 kilocal for her. And we aim to have around 135 grams of protein. But that was an estimation. So we base our goal on the labs that we received. Next. So we wanted the weight gain to stay between the two yellow lines that we see. So she did well on that. She was the kind of ladies who like to have fries and colas and all sweet food, juice. So that was really hard for us to control the calorie. But she did a good job having more vegetables and more fruits. And we had a challenge with the money, because she didn't have the money enough to buy fresh vegetables. So we had her to buy congelé. Elise, can you help me?
Yeah,
Freeze
frozen.
vegetables. Yes,
Frozen.
I found it. Frozen vegetable. Thank you very much. Sorry about that. So we were able to help her with that. Next slide. As soon as we learned about her pregnancy, we did a full labs to make sure that everything was fine, as she didn't have folic acid before pregnancy. She wasn't having all her formula. To be honest, I think she didn't took any formulas from after her leukemia until the pregnancy. Maybe she would have sometime during the week, but not every day. So we asked her to go back on formula. We explained why it was so important. So for the follow-up, we asked her to come in Quebec City at the beginning of her pregnancy, so we can do teaching. She could see the geneticists. We can do all labs at our hospital. And then we had a collaboration with the physician or family doctor and the nurse in the north of the province to help us with the follow-up. So weekly we did the amino acid profile, but even though it was sent rushed to the lab in Sherbrooke, it took always a week before we had the results. So adjusting the diet was not so easy. We did every 2 weeks the NTBC dosing and the succinyl acetone in blood and urine. And monthly, we did the full count blood cell and some other labs also. We did a fetal ultrasound at 12 weeks, 20 weeks, 24, 30, and 35 weeks pregnancy. At the 20th week of pregnancy, we also did a cardiac fetal ultrasound. Next, to make sure that everything was going well with the baby and everything was good. The dietary management and medication follow-up. Medication, she was really compliant to her NTBC, so that helped us to be safe with this pregnancy. But about the dietary management, it was really hard because this patient was not compliant with the diet. She used to go to McDonald's and having we have the poutine here in Quebec, so that's fries with cheese and sauce, gravy. So she had regular cheese before her pregnancy. She already ate meat also. So we had to explain that it was really important to avoid high protein food during her pregnancy to have a better tyrosine control. She didn't count protein, so we tried simplify the diet. We didn't have any food record during pregnancy, even though if we've been asking for, it was too hard for her. So we tried to do a 24 recall with her many times during pregnancy to see what she was having for each meal and snacks. We found out that she had a financial health from the hospital to buy vegetables. So that helps us to maintain a good control of phenylalanine. As she was not observant to her formula, she was motivated by the pregnancy because she wanted the baby to be healthy. So she was able to take 100 grams of protein equivalent from formula. But before pregnancy, like I told you, she was not observant to she was not compliant. We know that she was many weeks without taking any formula. Sometimes she was taking between 30 and 40 grams of protein equivalent. But during pregnancy, she was pretty good and she was honest with us. She was taking between 80 and 100 grams. It was mostly composed of a GMP-based formula, but she had to take tablets too because it was too difficult for her to drink all the formula required to fulfill the needs. We think that she was taking around 20-25 grams of natural protein during pregnancy, but it was so hard to estimate. The medication she was taking at that time, and as soon as we learned about the pregnancy, we added folic acid as supplement. And during the pregnancy, following the lab results, we need to add supplement of calcium and zinc because the zinc level, blood level was low, and calcium because she wasn't able to fulfill her needs. Next. So there's a tab with the plasma amino acid profile. I put some of the essential amino acid up there, but not all of them. I wanted to show you before pregnancy. The first line in March 21 was before pregnancy. So we can see that tyrosine level was pretty high, and that she had low level of threonine, methionine, and isoleucine. When she got pregnant, she had also some essential amino acids were low, but tyrosine level was not too bad. And we see through pregnancy. So between October and she delivered at the end of April, we can see that her tyrosine level was mainly controlled beside Christmas time and New Year's time, which probably had high protein food, and we see that tyrosine level rise up to 720. But she had pretty control of the essential amino acids during pregnancy. And when we see after pregnancy in May, we see that the tyrosine level rise up and all other are normal because she was having a high protein food for sure. Next slide. So she had a baby boy that born at the end of April 2022. It was born at the 36th percentile and the height at the 6th percentile. We didn't allow breastfeeding as the guideline mentioned it because the NTBC go through the breast milk, but we know also that NTBC go through the barrier of the placenta. So the baby was born with a high tyrosine level. It's not high for a tyrosinemia baby, but we know that the baby was not tyrosinemia because the father was not a carrier. So we plan with our team to have the baby on the tyrosinemia formula for the first day of life to bring the tyrosine level in the normal range. So our colleague in Saint Justine did that. So we follow that plan to be sure that the tyrosine level goes down. So I wanted to have the NTBC level for that baby, but because he was born in the north of the province, the lab didn't, we missed that lab, we don't know why, it just that never came, the result never came, so I don't have it, but we presume that the NTBC level was high as it goes through the placenta barrier. So we did a washout for 48 hours just to make sure the tyrosinemia goes down. As you see, he was born on April 27th. So we did the tyrosine level 2 days after born. He was at 340. And we did for 2 days after. We gave him a regular formula mixed with half and half with infant tyrosinemia formula at day of life 3. And at day of life 12, we stopped the tyrosinemia formula. And as we can see at the end of May, the tyrosine level was normal. So I'm not sure that we, with a future pregnancy, we will do the same, knowing what we know now about the tyrosine level, as it's less than 600. But we will need to talk with our team to see what we will do with the next another pregnancy and another baby. Next. What I wish I knew. Keep an open mind about all the tyrosinemia patients. Keep an open mind with combining formulas and offering different products to fit metabolic needs, lifestyle, and preferences. We see that we start our babies on infant tyrosinemia formulas, but as they grow up, they have taste, the volume is a concern. So keep an open mind to offer different things. We even do have some patients that are on amino acid formulas that they're 12, 13 years old, and they don't want to switch to other formulas, but we can fulfill their needs. So we use sachet that are more concentrated to add to the acid amino formula. So that may be helpful for some patient who doesn't want to switch to other formulas. Nutrition fact label runs up or down. When we see the labels for counting the protein, 0 gram, maybe 0.49 grams. This will be essential to know if for younger children. So when the label, we have a food that said 0 gram of protein, it could be 0.5. For older patients, we don't really care because the sensibility is not the same. But for young baby, we will see the ingredient on the label to see if we can estimate that there's some protein or not, and maybe we will ask family to count 0.5 for some food. Just be aware of that. That 0 gram doesn't mean that there's no protein at all. Keep also an open mind. We teach our family to know that gluten-free food can be low protein food, like breads, like waffles, but not all of them are low pro food. It's the same for vegan food, like we have there's yogurt that we can have now that are plant-based food. Some are really low in protein, like 1 grams per 170 grams of yogurt, but some are really high in protein. So teach your family to be aware of that. They're not all low protein. Be alert if you have a non-adherent patient with a low plasma tyrosine level. Question them if they could have missed NTBC doses. That could explain why tyrosine is low, and you know that is not compliant with the diet. Diet management maintains your health. I always tell my patient it saves your life. It's not just maintain your health. And TBC plays a crucial role in reducing the risk of life-threatening conditions. And teach parents that positive attitude can change the future. We know right from the first meeting that we have with them if it will be easy or not to go along with the diet and the treatment. So we teach them that if you say poor kids, it will be poor kid all lifelong. And if you tell them you're lucky there's a treatment. There's so many food now. I've been in the field for 22 years now, 25 years as a registered dietitian, but 22 years in metabolic. And it's just crazy how variety we have now in the grocery stores, in low protein food field. So just tell them that they are lucky. We're teaching them for Halloween, for all the special anniversary that they have, to have low pro food and low pro goodies. So just be positive with their kids, and that will help a lot. And it's the same for grandparents, friends around. They're all there to help with those kids. Next. Those are our references. So if you have, I don't know, Taylor, if you want to add something.
No, I think you wrapped it up very nicely. So I think those are all of the key points to take home. And I know we went a little over, but we had a lot of great information to give. So apologies there.
We're up for question if you have some.
Yeah, thank you so much, Taylor and Marie-Helene, for such a great presentation. At this time, yes, if anyone has questions, please type them into the question and answer pane or the chat. It's such a great opportunity to ask two experts questions. This is from Sarah. Thank you for the great presentation. Is there a specific time you have patients do blood work in relation to their NTBC dose? Good question.
I'll let you take that one, Marie-Helene, if you have any specific recommendation that you give.
We don't have any recommendation about the NTBC doses for the blood test, but for the plasma amino acid, we go usually 3 to 4 hours after eating. If it's for babies, we will try to do just before a bottle or breastfeed.
I was going to say the same thing. We do about maybe 2 to 3 hours after a meal. Yeah, same thing.
Okay.
Not
great.
always ideal with clinic visits, so we tend to do things on the fly as needed, but ideally that's what we'd want to do.
Same for us, but for the NTBC, we don't have any, because I think the half-life is kind of 24 hours or something like that. So we don't have any recommendation about that.
Okay, Callie has a question. What drives your management more, succinyl acetone levels or NTBC levels?
I can say for us, we manage the diet with the plasma amino acid profile, and the NTBC levels are, we take a look at them because we know it influences the tyrosine level, but it's that the NTBC is really managed by the physician. So we will adjust the diet with the plasma amino acid level. The NTBC will be really changing for babies, more stable as they grown up, and for adults, unless the weight is changing a lot.
Okay.
And I think for me, I would say that the succinyl acetone would be probably more significant for the physicians because they would need to know whether the dosing was correct or compliant. So if they had succinyl acetone, that would be of great concern and wouldn't necessarily be managed dietarily or wouldn't be managed dietarily, but the plasma amino acids is more what we look at. And if, and we look at, again, like with the case presentation, the NTBC treatment can affect your dietary management. So taking a look at what the level is, or if any dosage changes have occurred is important, but we wouldn't necessarily use the NTBC level to determine our dietary management. It would be the plasma amino acids.
I agree.
Okay. This is from Christine. Is there a specific time of the day you recommend to take the blood samples for the Phe and the tyrosine?
Yeah, I think, like we said, the 2 to 3 hours after a meal. So I think that would be the main timing that we would ideally look for. or, right before feeding if it's an infant. Yeah, we don't normally, because we can't really schedule appointments based on ideal times of day. So it would be difficult. And I know with our PKU patients with taking filter papers at home, that can be different because they can determine what time they want to take it. And we usually just recommend them to be consistent with their time that they're taking their level, but we don't really have that luxury for tyrosinemia patients coming into our clinic.
The same for us.
Okay, great. Well, I do not see any more questions. Again, I just would like to thank you, ladies. This was really such a wonderful presentation. I'd like to thank our audience for joining us this afternoon and for your participation. On behalf of VIA, VitaFlow in association with you, we hope that you found this information valuable to your practice and that you have a great day. Thank you.
Thank you all.
Thank you. Have a great day.
Bye.